Hey, good day, everybody. I'm Dr. Paul Pepe. I've been asked to talk about our recent projects bringing whole blood to the civilian pre-hospital setting, or as I call it, Leviticus meets EMS. Um, uh, if you don't follow this or you want to read more about this, the company yearbook that goes along with this conference has a paragraph in there that I can talk about this in more detail and also talk about the two centers we work in. One is in Broward, Florida, Broward County Sheriff's Office, and then the City of San Antonio Fire Department. All right, let's move along. So again, I have no disclosures or conflict of interest to declare, and as we'll move on, except to tell you that I'm not a morning person, so I appreciate that I'm able to do this virtual thing, especially for someone from the U.S. who is going to be time lapse and have my problems with the sleepiness early in the morning, usually in Brussels. So I wanted to also thank everybody for the opportunity to become one of the speakers here today under these circumstances. They did have to scrape the bottom of the barrel to get me here, but I do have to say that I have been promoted from non-significant to non-essential here. So we'll see how that goes as we get through here today. Like most veterinary students, Doreen breezes through chapter 9. So here's equine medicine taking care of horses, and you can see the diagnosis of broken leg, infected eye, spite of treatment is shoot, 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 shoot. So we're going to start breezing through here. The major principle of trauma care, of course, is stop the bleeding. And the reason why I talked about Leviticus, because in the Bible it says, for the life of all flesh is the blood thereof. And the concept is that you got to have, oxygen carrying capacity. That's why we set up trauma centers where people could be standing by to stop the bleeding, get right to it, particularly if you have either intracranial or you have internal bleeding that has to be controlled rapidly. In the interim, over the years, and you can see this photo is taken from 40 years ago, we started trying to treat people that had low blood pressure to reperfuse the tissues, which the concept that we were trying to get across with IV fluids. And we use oftentimes isotonic fluids, sometimes hypertonic fluids, colloids, crystalloids, whatever it was, but that became the common approach. And as many of you know, I actually did a paper, what's this says, we did the study back in the 80s, early 90s and published it in 94, where we actually looked at this and found we had worse outcomes when we had patients who we gave the fluid to versus those we held up until we gave them either blood or got up to the operating room. So at that time, we were thinking that uncontrolled hemorrhage basically accelerated the hemorrhage if you gave the fluids. In an uncontrolled hemorrhage, you basically had a mechanical clot disruption, by hydraulically raising the pressure, et cetera. And then we observed that it was diluting of clotting factors. And at that time, we didn't think much of it. We just had an inference that is, that's too bad. It hurts that as well. So the takeaway points at that time were that it's first your pants, then your shoes. Well, as it turns out, and that means that first control bleeding and then you can give the fluid. So that would be fine. What we didn't realize at that time is that there is much more to it. And fast forward to the 21st century, the Iraq experience that U.S. military had at least one silver lining, and that's Dr. John Holcomb there, who was the head of research there, a terrific person. I do a lot of collaboration with. And they brought back the concept of using tourniquets, introduced some of the topical products, which actually led to a new thing, which not mechanical control, but we're talking about now a non-mechanical control of hemostasis. And that was the first thing that made us think about it. And we'll talk about later, maybe if we had time, the TXA and all those things. But the key thing they found was giving fresh frozen plasma out there in the pre-hospital arena, so to speak. And we then had that translated here to our civilian air rescue programs, or more recently, Sperry published a really cool paper in 2018 in which they showed they had better outcomes if they gave plasma while they were out there. It was a marginal improvement, but it was still something. We have begun to learn in the laboratory that what happens is fluids tend to come in and kind of wipe out the glycocalyx. And where in retrospect, it turns out that the plasma that we give actually helps to preserve it and protect it. And most of you know that the glycocalyx is that protection over the endothelium and then protects that and prevents it becoming leaky or multi-organ failure when we wipe out this protective layer here. So it turns out that it appears that plasma, and therefore we'll see other blood products, actually tend to spare the glycocalyx, then you have less complications. In the Army, when they started using red cells and plasma, and this is a paper published in JAMA not too long ago, they did show that of when they looked at soldiers who got 1:1:1 of platelets, red blood cells, and fresh frozen plasma, it improved the 24-hour, but more importantly, the 30-day mortality was improved in terms of only 11% dying versus 23%. So that brought back the concept: why are we giving 1:1:1 if you have to give 3 different products? How about if you just give blood? Okay. Of course, we've always had this issue that we've got to type and cross-match the blood and all that before we give it. But let's talk about that. We're going to see there's a good rationale for not having to worry about that, okay? Again, for the life of all flesh is the blood thereof. So why don't we go for blood? Whole blood has some terrific advantages. In fact, if you compare it to the component therapy of 1 pack red blood cells, the platelets, the fresh frozen plasma, and cryo, which is a cold issue. One of the things I'm about to show you today, the new approach we're using, is that we're able to actually warm the blood immediately. We keep it very cold, but when time comes to infuse it, we can give it in this one shot warm. Secondly, the hematocrit of most of this component therapy is a little lower, 29% versus the 38 to 50% of blood. Platelets are lower, as you can see here, and I'll even circle them for you. And then, of course, the coag factors are working really well in blood, whereas they're not. And that's going to be key to what we're talking about. So plasma works. Why doesn't it work really well with whole blood is the question. And we go, why not? Let's go for it. The other thing is that weight is the same, size is the same, but it's only one infusion. Ask any nurse in a trauma center, would they rather just hang blood, or would they like to give all these components? And they'll tell you. And we see the same thing in the pre-hospital arena. So is it possible to give blood in the U.S. civilian sectors? How do we get this done? So I'm going to give you what I call a tale of 2 counties, okay, here briefly. Giving blood in the field is going to be a project that's underway in many counties, but I'm going to tell you the 2 that I work with: San Antonio Fire Department over here on your right, and there's me with the Broward Sheriff's Office tactical team, the SWAT teams there. So we brought it into both of those counties, and the rationale for using this is that O negative is the universal donor, but only 8% of people have O negative, and of course, men, therefore, with O negative is about 4%. So we tend to spare that for use with women of childbearing age and other special conditions, cancer, neonates, etc. And O positive is about 40% of the population. So the question is, could we use it? Turns out that 75% to 80% of those have low titers of the anti-A and B. And so as a result, it may be that it's not harmful. And sure enough, that's the case. So we have a large percentage of the population that has basically a blood type that is actually not going to be a problem. Recent military use of low titer O positive blood has had over 500,000 transfusions, no reactions seen when there's titers that they can find of less than 1 to 1,000. In fact, they had very little TRALI, which is the transfusion-related acute lung injury. And now we're recommending, to be a little safer, is less than 1 to 256 in the civilian populations of the IgM and IgG in that regard. So we can use male donors, and that's about 15% of the population if you're talking about 75% of the total, and half of those. There's been some hesitancy because of HLA, the particular factor that some women might have, but we're getting maybe around that one as well. We'll explain that because we can test for it. So how is the blood maintained and how is it given? So in San Antonio, there's something called a product. Again, I have no conflict of interest. There's a product called the Credo Cooler that we can use, and it stores things at somewhere between 1 to 6 degrees centigrade. In Broward County office, the Broward Sheriff's Office, we're also using another product there. And what's kind of cool is that the blood that we have set up is set up to see if it exceeds the range. We try to store it between 1 and 4 degrees centigrade, and if this thing turns red, we know the blood's gone bad. But otherwise, it's kind of a neat system, and it works, and we can store it for quite a while. The QuinFlow is what we use. It's a machine that actually takes something from 2 degrees centigrade to 37 degrees in minutes, and infusion in minutes, etc. And I won't go through the details of it because of the talk, but we've now introduced it again in different places. And here's your Credo carrier in San Antonio. They had a plan to see inside their county, where did they have most patients with hemorrhagic shock sort of picture? 7 patients in this realm, 5 patients here. So they targeted certain areas and started off with a certain number of units that they would use to respond. So they had 8 units, that is EMS ambulances and response vehicles, carry one 500 mil bag. They stored it in the cradle cooler, as I said, the cradle cooler. And it has stayed good for 35 days, but we're recycling it at 14 days back to the trauma centers where they can use it for cardiac surgery, trauma, whatever it might be. And there's no cost to us there for unused blood. And if we use it, it's 500. Turns out we use it about 60% of the time. So if you look at a 26 weeks over that period of time, $2,400. And based on the current number of people that we are saving, it looks like it costs me about $4K per life saved. And so that's gone well on our budgetary approach so far. You're going to have to extrapolate from that. I can't talk about that quite yet because we have some data out there, but we can't present it yet. All right, what's the source? Well, there are a lot of people, including military, but also first responders, others, and whom they have gone down, delivered blood. We see that they are low titer. When we say you're low titer, they can sign up for the program, and a lot of people have. So we have a really terrific source of the blood. And so it's been kind of cool to have that happen, and we really appreciate that there are a lot of people who participate. So we've got a lot of source of that blood there donated. So why we haven't been doing this? Again, the transfusion reaction fears. The main worry has always been the women of childbearing age who are Rh negative, being exposed to the Rh factor and developing antibodies, which would put the next baby at risk. But in terms of what we found is based on our data, the transfusion protocol of low titer O positive would take 3,000 months to expose 100 women of childbearing age that were negative to receive the O positive blood. And based on the known data conversion rates, only 3 of the 30 would develop those antibodies during that period of time. And without the transfusion of the O positive blood in the whole pre-hospital setting, nearly 500 women of childbearing age would have died from the hemorrhage based on our current data. But I'll leave that at that. So I think this has been very interesting. And again, would you survive to have that baby is the next question, which is a good point. So bottom line, there will be blood. Okay.